All right, so let me share the live stream link with you. You can send it out.
Okay, I see it coming up on the screen.
Mm-hmm.
We can share this.
Mm-hmm. So I'll send it in the chat to you now. That's the link to the live stream.
Okay. Thank you.
No problem, fam. All right. So Dr. Aarons, and then we can go. It's 6:30 now. I'm sure people are bubbling to come in. I can let them in, but I don't want Dr. Aarons to have any questions about how we do things. Send it in the chat to you now. Dr. Aarons here. That's the link to the live. Thank you. No problem. And you can hear this, right? Sure. You're hearing this, right, Chris?
No, I'm not hearing any audio. I'm seeing the video, but not hearing the audio.
That's fine. That's why we do test runs.
Hello, Sam.
Hey, Doc.
Sam.
Yes, Dr. Gordon?
Hi.
Yes, Dr. Gordon?
Hearing that song, hearing that.
Greetings.
Hello,
Thank you
Sam.
for having Medimpex Jamaica here today. Showcase.
Hi, Dr. Gordon. Yeah, I'm hearing that you're talking to me, but it's not coming through as clearly.
Hello, Sam.
Yes, Doc. Can you hear me? Yes, Doc. Hi, Dr. Gordon. Hi, Dr. Aarons. Thanks so much for joining us, sir. Thanks, sir. You joined just in time. We want to begin, Dr. Aarons, but I just want to know, you have any questions about sharing your screen, anything like that? All is well on your end? Can you hear me, Dr. Aarons? Dr. Aarons, can you hear me? Hello? Chris, you're hearing me, yeah? Chris, can you hear me? Yeah.
Yes, Sam, I hear you. I hear you.
Awesome. Dr. Aarons, are you hearing me? Dr. Aarons, can you hear me, sir? Dr. Aarons? Can you hear me, Doc?
Mr. Dennis, are you able to hear me?
Yes, I can hear you now. Can you hear me?
Speak, let me hear if I'm hearing you, please.
Speak to him.
Mr.
Speak
Dennis,
to him, Chris.
You're muted.
Dr. Aarons, I'm here. I was hearing you. Are you hearing me?
I'm not hearing you. Let me see if my microphone is at max. Is my
Your volume?
Gonna have a funky good time. Chris, call Prof. Bailey here. Hi, Dr. Aarons. Are you hearing us now?
Dr. Aarons, can you hear now?
He said this needs to be cooler. That's why.
Doesn't seem to be hearing.
Here is my earpiece.
Hey, Doc, are you hearing us now, Dr. Aarons? Chris, can you call Doc and tell him that his speaker needs to be checked?
All right, let me try and get to him.
Thanks so much, man.
Good evening, Donald. Are you able to hear me? Donald, can you hear me? Mr. Dennis, can you hear me?
I'm hearing you, Dr. Aarons. Can you hear me?
Yes, I'm hearing you well.
Okay, good.
No,
Sam,
just
you ready
speak.
for that?
Speak once more. Let me.
Are you good, Dr. Aarons? Are you hearing me? Still hearing me?
Okay.
Loud and clear?
Yes.
Sam?
Thanks.
Beautiful.
Hi, Sam.
Hi, Len.
I'm on. Dr. Bailey said he was having some challenges. I sent his number. Can you call him?
Somebody joined with Dr. Bailey's login.
Really?
Yeah, somebody's online and their name is there as Dr. Bailey. And I'm trying to get the person to acknowledge me and nothing. So he will be having problems because he's probably shared it with his assistant.
I'm calling back again.
Okay.
Dr. Bailey? Dr. Bailey?
Yes.
Somebody joined already with you, with you shared you're joining with somebody, you're logging with somebody because somebody's on already with your name. So the person has to log out and get out their own login.
They just logged out. So if he logs in now, he'll get in. They heard me and they logged out. So he can log in now, Lynn.
Yeah, Dr. Bailey, try log. Dr. Bailey, are you hearing me? The person has logged out, so you can log in now. I don't know, you probably shared it with somebody. I see you.
There he is. Yeah. Hi, Dr. Bailey. Hi, Dr. Aarons. Hi, Dr. Richards. Hi, team from Medimpex. Hi, team from Agpj. It's good to see you all.
Hi, Sam.
We're looking for a wonderful evening here. I just sent out a blast to everyone who's registered with the YouTube link. We have over 2,300 persons registered, and we're excited about that. I'm going to go live now. I can imagine your phones are blowing up with people saying what's happening with the thing. So we're going to go live. I just have a question for our presenters and our moderator. Are you guys okay? Do you have anything you need from me? I have spirits. That's about it.
Good to know. Hello.
Once you're willing to share.
Yes, always.
Very true, Dr. Aarons. Sam, I just wanted to know, when you find the highest number of participants,
Yes.
to just let me know what that number is.
Sure. It should pop up. It should pop up for you. If you look on your Zoom screen now.
The highest number, I would love
no
to
problem.
know that.
No problem. If you look on your Zoom screen though, where you see
Good
participants and it
afternoon,
says
Dr. Bailey,
6.
Dr. Aarons. Is Dr. Gordon here yet?
Yes, he is.
Just
Yes.
saying hi as well.
Oh, hi, how you doing? Sam, just a
Yes,
quick
sir.
one. When I introduce the panel discussion, I would like to say a few words before you actually give that poll quiz.
Sure.
After the poll quiz, I'll then share some slides with a discussion on the answers.
No problem.
Sorry,
Well,
Dr.
would
Bailey,
you
we
like
weren't
me to?
hearing you. Weren't hearing anything that you were saying a while ago.
Yeah, I think you guys are muted in the room, Chris. So hold on, Doc. I have the poll here. You
Yes,
should see it pop up now as an
right.
example of what would happen. You want me to share the PowerPoint as well at that time?
No. I have my own PowerPoint. I'm going to have a
Okay,
discussion about it. So I'll just indicate to you when the poll should start,
sure.
and then subsequently I'll continue with the discussion using my PowerPoint.
Sounds excellent to me.
Okay.
Any other questions? Anything from anybody else? And Doc, I did get your Dr. Richards. I did get your request about the numbers. We should top out somewhere at 1,000, but I'll also try to include how many I see online on YouTube as well, so you're aware. All right. Dr. Aaron's all is well. Ladies and gentlemen, I must tell you, I don't say this all the time, but you look good. And when you look good, you perform well. And so I know you're going to have a wonderful afternoon. I am here. Say, Sam, help, and I will help as soon as I can. But I doubt you'll have to do that. Have a wonderful afternoon and enjoy.
Thank you.
Thank you.
Good afternoon, good afternoon, good afternoon. Thank you, guys. Thank you so much for joining us wherever you are. If you are driving, please be safe. If you are seated, thank you so much for taking the time to join us this evening as the Association of General Practitioners of Jamaica, in association with Medimpex Jamaica Limited, brings forward for you this Ethics Webinar 2023. My name is Samuel from Allgate Solutions, and I'd like to thank you all for allowing us the opportunity to work with you and collaborate on this wonderful event. I see where there are some 708 of you. Thank you very much. We do have a YouTube link and we're streaming live on YouTube as well. I'll share the YouTube link in the chat so you can share with your colleagues. Once we get to 1,000 persons online, it's going to prevent everyone else from logging in, but let them know it's live on YouTube so they can go on YouTube. And if for some reason JPS does a why comes, how comes at your house and you get chipped out, once you get back your internet, you can come and see us live on YouTube as well. Good evening to you all. Have a wonderful day. Professor Alverston Bailey, I hand over to you at this moment, I believe, as moderator of the day to do some introductions.
Actually, Sam, no, the welcome and opening remarks is by Dr. Gordon. Over to you, Doctor.
Dr. Gordon, apologies. Dr. Gordon, over to you, sir.
Donald, you need to unmute.
Good evening. Hello.
Hi, Dr. Gordon. I'm hearing you. Can you hear me, sir?
Hello, are you guys hearing me?
Yes, Doc. I'm hearing you. All right, we seem to be having some technical difficulties at the moment with Dr. Gordon, perhaps some internet issues. We know how those things go. Based on my agenda here, if Prof. Bailey will allow, I think we can ask the supervisor for the medical reps from Medimpex, Mr. Paul Dennis, to do a sponsors welcome. And we see if we can work out those technical glitches with Dr. Gordon. So, Mr. Dennis, over to you.
Thank you very much, Sam. Welcome, everyone. As a representative of Medimpex, I am excited to be a part of the annual ethics webinar in partnership with the Association of General Practitioners in Jamaica. We are grateful for the support of Dr. Donald Gordon, President of the AGP, Ms. Leanne Thomas Hyatt, the Secretary, Mr. Samuel Heron, our tech person, and Dr. Alvaston Bailey, our moderator. I want to express our gratitude to all the esteemed professionals who have registered for this webinar. Your presence and support are greatly appreciated. Last year, we had a remarkable turnout with over 1,000 persons participating. This year, we are thrilled to have over 2,000 registered attendants. This year's webinar focuses on ethics and mental health, which is of great importance as Medimpex markets and distributes products related to mental health, such as your Palixid, Stimulotan. We are committed to working alongside you doctors and healthcare professionals to ensure the provision of quality pharmaceutical products for our patients. Our motto is first-class products for healthy living, which reflects this dedication. In keeping with this, even though it's not related to tonight's topic, we are proud to have added this year our newest product, Amlotor, which is a combination of amlodipine and atorvastatin for dyslipidemia and hypertension. I'm also delighted to introduce our hardworking and dedicated medical representative team consisting of Ms. Lisa Hubbard, Ms. Sasha Dixon, Ms. Paulette Bedward, Ms. Melanie Miller, and Mrs. Cheyenne Megu. They will be available to assist you and provide you with any information you need regarding our products. Once again, welcome to all, and I hope you have a productive and inspiring time during this webinar as we listen and interact with our esteemed speakers. Thank you for being here. Enjoy your meeting. Thank you.
Thank you so much, Mr. Dennis. And we go back now to the head of the AGPJ, Dr. Donald Gordon. Over to you, Doc. Dr. Gordon. So I'm seeing where your camera is open. I need you to unmute for me, Doc. All right, I'm going to have to call Doc directly and just see what's really happening on that end. But we have 868, wow, attendance so far online. 871, it's climbing. Good evening to you all. Prof. Bailey, I think we'll hand over to you, and if you'll allow, sir, when we sort out the situation with Dr. Gordon, I hope you'll allow us to come back to him, because I know he'd love to welcome and thank everyone for taking the time out.
Okay, Sam, thanks much. Colleagues and friends, it's for me a special honor and privilege to have been asked by the Agpj to moderate this session. I've been in practice for over 40 years, and I can assure you that I have attended most CMEs that Agpj have put on. But I think this evening is going to be really special. because in my 40 years of practice, I've never really seen a topic that is so interesting and so highly controversial, yet so important as the issue of ethics and mental health, and particularly the issue of gender identity and how we as physicians should take care of ourselves. I must congratulate the AGPJ for conceiving of this seminar and getting two eminent speakers to share their thoughts with us. I'm also pleased that I've been asked to participate in the panel discussion, which I can assure you will be quite stimulating and interesting, and for some of you, a little challenging. But we know that by the end of the evening, you'll emerge from this experience better informed and much more able to cope with the challenges of mental health issues and behavioral nuances in our practice. The first presenter for this evening is my good friend and colleague, Dr. Derek Aarons. Dr. Aarons is a consultant bioethicist and family doctor who did his master's specialization in bioethics at the McGill Care for Medicine, Ethics and Law, and his PhD in experimental medicine and bioethics at McGill University in Montreal. He is currently serving as the ethics consultant for the Caribbean Public Health Agency, CARPHA. He is a adjunct assistant professor in the bioethics department at Clarkson University, New York. Dr. Aarons is also the author of the book Vital Communications in Medicine, which is available online and at all branches of Sciences bookstore in Jamaica. His book addresses the critical issues of communication between doctors and patients. Dr. Aarons comes to us eminently qualified and experienced in ethics. And he has decided this evening to take on an ethical challenge, which I've never heard discussed before. And it is ethical dilemmas surrounding gender identity. Ladies and gentlemen, all 921 of you, therefore, takes this opportunity to invite Dr. Aarons to come to the podium and make his presentation. Over to you, Dr. Aarons. Dr. Aarons, it's your time.
Yeah, Doc, you were there a while ago. Seems there's an internet issue by you as well. If you could unmute for us if you're hearing us. All right, there you go. Seeing your presentation. Needed to unmute as well, Doc, so we can actually hear you.
Dr. Aarons, we are not hearing you. Sam is also, his screen sharing also seems to be compromised.
Agreed, Prof. He seems to be having an internet issue at the moment. Not sure why. Assume his provider is giving him a bit of a problem there. Yeah, his image is frozen. Let's just give him a little moment. But again, I want to thank all 964 of you for joining us online. I want to thank Prof. Bailey for taking his time out of his busy schedule to support the AGPJ and be our moderator for today. Dr. Aarons, I see that you're back with us. Can you hear me, sir?
Yes, I'm hearing you well. Are you able to see
Wonderful.
my presentation?
At the moment, we're seeing you and hearing you, but not your presentation. If you share your screen,
Okay.
we should
I
be able
tried
to.
sharing and there was a technical hitch. So I will try again and see what happens.
All right. So we're seeing ethical dilemmas in gender identity. Just ask you to go to your slideshow view. Yep.
That
Perfect.
should be it. Good evening, everyone, wherever you are across the Caribbean and perhaps elsewhere. And thank you for inviting me to address this very important and topical issue currently being discussed in so many societies. First, let us start by asking, what is an ethical dilemma? Simply put, it is a situation in which we find ourselves faced with a difficult choice that has to be made between two contending courses of action, either of which may involve transgressing an important moral principle. With all the discussions that have been taking place over the past decade regarding gender and gender identity, we can see how the numerous considerations around this issue could produce ethical dilemmas. So, to examine this matter, you must first have our concepts clear. I emphasize the importance of getting our concepts clear and correct at the start, since I will never forget, while doing my graduate course in scientific medicine during my PhD at McGill, my sage, heavily bearded senior professor stating on the very first day of class that concepts matter. They matter enormously. Concepts matter. They matter enormously. And he would re-emphasize that phrase throughout our scientific medicine course. Concepts matter. They matter enormously. And you can see why. The way in which we view the world and what is happening within the world has much to do with the concepts that we have. All persons consider topics and issues from their own, using their own particular beliefs and life experiences. So, for example, persons of faith will often use a religious prism to view and discuss topics. And some persons who place great emphasis on rights may use a human rights approach when discussing interpersonal issues. So, to illustrate how we may all look at the same person, object, or thing, and yet may see things differently, let's look at this picture. How many legs does this elephant have? What we see often depends a lot on what we bring to the table. And we don't always realize that other persons may see something different from what we see. And so we may say that they are wrong or talking nonsense. Further, we often label people and forget the fact that we are talking about human beings. Some of these persons may be stigmatized by the wider society and are thus very vulnerable to being hurt by those labels. A dilemma occurs when those persons may need help or healthcare, but stay away as they are afraid of being labeled and mistreated. Fear can make some people very defensive, and yet it may be difficult for us to put aside our personal feelings without judgment, since such feelings may have been ingrained in us from childhood, that some people or some kinds of people are to be scorned. Let's now look at the matter of gender identity. First, we must ask, what is gender? To answer that, we must first have a clear concept of what is sex. Our sex is normally assigned at birth, but we should be aware that the issue is more complex than simply looking at how the newborn genitals appear to our eyes. Biologically, we recognize that there are many considerations to be made at birth, including the various combinations of X and Y chromosomes and the XXY among other chromosomal combinations. We also have to determine what is the particular biological makeup of the gonadal tissue. How is the physical appearance of the external genitalia affected by endocrine hormones? Unfortunately, therefore, this issue is not always simple, which now leads us to consider the matter of gender. We should note that the matter of gender is not biologically based. It is society based. When we are born, two things are checked. One, whether we are breathing, and two, what our morphological sex appears to be. Thereafter, gender socialization commences. Our particular society begins to teach us what is expected of us as a boy or a girl, whether we should be masculine and strong and not play with dolls, or be pretty and do house chores in the kitchen, and so on. However, the fact that gender is socially constructed is sometimes forgotten, and some people treat gender roles as if they are inevitable and a product of nature. The reality is, as we grow, we learn masculine and feminine social sex roles that arise from our particular culture, which leads us to consider the matter of gender poles. This is related to how gender roles are taught. Men are from Mars and women are from Venus was the title of one bestseller on the subject. What are the qualities traditionally associated with socially acceptable behaviors for men and for women? They are usually described as opposite poles. Thus, when we speak of gender, we are also talking about a spectrum of those qualities considered to be feminine or masculine. This comes from the concept of poles. So we have hard and soft, and various shades in between, intellectual and emotional, and shades in between. We may say these are false dichotomies, but they have a power in the world that we still have to deal with. So we can now see, simply put, that sex refers to the anatomical organs we were born with, while gender refers to how we are reared as a child, what society expects of us, the multiple meanings and expectations that exist in various parts of the world. Accordingly, the World Health Organization states that gender refers to the behavior and attitudes that a particular society thinks is appropriate for their men and women. So therefore, how is gender learned? First, we should recognize that gender is not a dichotomy. It is not simply boy or girl, masculine or feminine. A certain percentage of all populations around the world comprise what used to be called hermaphrodites, but are now referred to as intersex. As a result of this reality, children will grow into a particular gender identity. They develop an internal subjective framework in regards to both their perceived sex and gender, which will inevitably determine whether they see themselves as male, female, or various combinations of gender expectations. In April 2014, the High Court in Australia ruled that people could be officially recognized as a non-specific sex. In other words, in addition to male and female, a third category of non-specific sex was recognized. The law there allows persons to be identified on their passports as male, female, or indeterminate, unspecified, or intersex. The High Court further declared that the sex of individuals is irrelevant to legal relations, and the only case where the sex of persons is legally significant to a relationship is the legal status of marriage. The High Court judgment noted that while historically there were two registerable classes of sex, this did not mean that people should be forced to choose between the two. The ruling thus allowed full recognition of persons who were born intersex or transgender persons who do not wish to be identified as either male or female. At the time, a Sydney University gender studies expert wrote that understanding male and female in dualistic terms is a spurious endeavor, and it demonstrates how out of step the law was with scientific evidence. A report in one of Jamaica's local newspapers over a decade ago described the verbal abuse meted out to a then 12-year-old schoolgirl who was born with both male and female genital organs. Perhaps not knowing which sex hormone would predominate in the later teenage years, at age 2 years, doctors performed a surgical operation on the child, which refashioned her enlarged clitoris, and the child was then raised as a girl. However, when the sex hormones stimulating the development of the child's secondary sexual characteristics began increasing at age 12 years, the child began to feel as if she was a boy by nature. This resulted in very insulting names within the community and a eventual withdrawal of the child from school in shame. In many societies, one of the first responses to the birth of a child with ambiguous sex, where the physical appearance of the external genital organs is confusing, is to seek to assign the newborn's identity as either male or female. Unfortunately, in some cases, surgical modification of the child's genitals to conform with the believed identity, sexual identity, may be done, and medical treatment may be given to reinforce the gender decided on. However, this approach is erroneous, with sometimes dire consequences. Stories such as these illustrate some of the ethical issues that may underlie any premature normalization of children born with cosmetically offensive or indeterminate anatomies. Estimates from the medical literature reveal that between 1 in every 500 to roughly 1 in every 1,500 live births have intersexuality or ambiguous genitalia. This constitutes a range of physical anatomical conditions in which an individual's anatomy mixes important masculine anatomy with important feminine anatomy. The ambiguous genital organs may not be due to any disease process, but simply constitute a failure of nature's formative process to fit society's particular definition of normality. However, a metabolic problem that occurs in some fetuses within the womb, congenital adrenal hyperplasia, may cause an overproduction of male hormones, which can result in the genetically female fetus becoming masculine, with resulting sexually ambiguous organs being seen at birth. If we are to respect each human being and their right to self-determination, it is important that we have a clear concept regarding how each particular individual perceives themselves. Their self-identification may also be expressed in several ways. So when we talk about transgendered people, transgendered persons, we should always bear in mind that we are talking about human beings who live in our society and who identify with another sex. Unfortunately, society is very harsh on persons who do not conform to the gender roles based on biological sex. And if there is already stigma against homosexual men and lesbians, the stigma and discrimination experienced by transgender people is even worse. Several publications exist in regard to research in children and adolescents, and gender variant behavior and so-called gender identity disorder, which reflects gender behavior as existing along a continuum rather than being a dichotomy classification of normal versus abnormal categories. Domains that are evaluated include gender development, the lived experiences of persons, prevalence, developmental trajectories, and treatment. Studies in the rural areas of the Dominican Republic provide another side to this issue. A rare deficiency of testosterone metabolism results in children that are genetically XY, that is males, being born sexually ambiguous to the naked eye. In that country, the children are often raised as girls, but at age 12 years, their voices deepen, their muscles develop, and their testicles descend. What was thought to be a clitoris enlarges to become more like a penis. And the child who was thought to be a girl or sexually ambiguous gradually becomes a boy. In these cases, biology outweighed the sexual socialization that took place, and testosterone prevailed. Consequently, while many countries code for only two sexes, areas such as those in the Dominican Republic provide a third code for the sexually ambiguous child. that country uses the term gravidoce, meaning penis at 12. So, similar to children born with clear and unequivocal male or female genitalia, children born with ambiguous genital organs also occur in nature as a fact of life. Accordingly, persons in all societies should be aware of this, and these children should never be treated as outcasts or sources of embarrassment, since the psychological effects of such stigmatization and marginalization can be devastating and permanent. Further, we should note that, according to reports in the International Medical Journal Pediatrics, a growing number of young children and teenagers who think they were born of the wrong sex have been receiving support from parents and doctors who are willing to give them sex-changing treatments in some developed countries. The issue, however, raises ethical questions, and some specialists urge caution in treating children with puberty-blocking hormones or drugs. The journal provided some examples, including one where a child was born a girl, but at 18 months announced a boy, and exhibited the gender role of a boy in growing up. However, the parents subsequently awaited the first signs of puberty to decide about commencing hormone treatment. One of the authors of the publication stated that pediatricians need to know that such persons exist and occur generally in medical practices and deserve treatment. We should also note that switching gender roles and occasionally pretending to be the opposite sex is common among children. However, in these particular children, they are special in that they believe they are born into the wrong bodies. While some persons are labeled as gender identity disorder, which would suggest a psychiatric origin, the authors reported that research is emerging which suggests that these persons have brain differences that are similar to that of their opposite sex. It is thought that somewhere between 1 in 1,000 and 1 in 10,000 children have this condition. That is, boys who tell persons that they want to grow up into a woman, or girls who say they hope to become men. The increased incidence of this diagnosis has occurred not because more children have the condition than before, but because more persons are now aware of the condition and are more likely to seek help. We should note, however, that offering sex-changing treatments to persons under the age of 18 years raise ethical concerns. And since parents' consent will be necessary, parents' motives should also be examined. We should also be aware that in many societies, gender roles are so narrowly defined that some children may be assigned a psychiatric diagnosis when they are simply just uncomfortable with the narrowly defined gender roles. Some children may actually have same-sex preferences, but may be coerced into treatment by parents who are uncomfortable with having a homosexual child and so would prefer a sex change for their child. Healthcare professionals are also divided on how to proceed. Many specialists think that it is harmful to have an irreversible treatment occurring so early. However, doctors who provide the service think that withholding the treatment would do more harm, since some children resort to self-mutilation in attempting to change their own anatomy, while some face verbal and physical abuse and are prone to stress, depression, and suicide attempts. One author stated that these problems typically disappear in children who have had the treatment and are allowed to live as the opposite sex. The guidelines of the Endocrine Society in the USA and the World Professional Association for Transgender Health both endorse transgender hormone treatment, but stipulate that it should not be given until puberty begins. At that point, the guidelines recommend puberty blocking drugs until the age of 16 years, and thereafter, lifelong sex-changing hormones with ongoing monitoring for any effects that may pose a health risk. The guidelines also stipulate that mental health professionals should be involved in the process. These guidelines have helped to increase awareness about the condition and treatment, and led many parents to seek help in the process. Administering the puberty blocking drugs up until age 16 years allows the child more time to think about things. The aim is to keep them from physically masculinizing or feminizing too much in their biological sex, which would make it a big surgical problem if and when that person then decides or tries to go to the self-identified gender. We should note that children do not initially have the capacity to make their own decisions about healthcare, and so an irreversible therapy should be avoided long enough so that the child can grow into his or her own decision-making capacity. Parents, as well as these children, should be advised, however, that when puberty is halted in young people before their bodies are developed, and then cross-sex hormones are taken for a few years, they will probably be infertile. Many children at that age may not be fully aware of the matter of fertility and its possible importance to them later on. And so this issue may be a flashpoint for awareness and discussion. A person born with male sex organs, but who experiences a female gender role, will have a deep male voice if sex hormone treatment is not started before male puberty sets in. The drugs used are those that are commercially approved to delay the onset of puberty in children who begin maturing too soon. The drug's effects are reversible and have caused no complications in the patients. The background rationale is to allow these children to mature emotionally and to make sure they wish to proceed with a permanent sex change. From the data compiled by one author, only 1 out of 97 patients opt out of permanent treatment. The vast majority proceeded. The author observed that if drug treatment is started early, children will more easily pass as the opposite gender and will require less drastic treatment later on. And so boys switching to girls will develop breasts, and girls switching to boys will be flat-chested if puberty is blocked and the appropriate sex hormone treatment begun early. However, sex hormones, especially when used in high doses long-term, can have serious side effects, including blood clots and cancer. Hence, treatment should involve low, safer doses and the effects regularly monitored. The literature suggests that gender reassignment surgery, which may include removing or creating penises, is only done by a small number of doctors on patients that are at least 18 years old. These surgeons have done breast removal surgery on girls at age 16 years, but such surgery may be minimized or avoided if puberty is halted in time. One author said that reports in journals have helped persuade more doctors to offer sex-changing treatments to these children, or to refer them to specialists that will help. Also, more young persons are becoming aware that transsexuality exists, and gender dysphoria or gender identity issues are now more commonly being diagnosed. The ethical issues surrounding this condition revolves in the main around the autonomy of a child. And doctors who prescribe puberty blocking and cross-sex hormones medications to minors are responsible for drawing the distinction between typically gender-bending behavior and the full-blown gender dysphoria, defined as a sense of unease that a person may have because of a mismatch between their biological sex and their gender identity. The criteria for gender identity issues or gender dysmorphia include a persistent preference for cross-dressing and a deep desire to switch gender roles. But doctors agree that such a behavior, when neither long-standing or intense, usually just means a child is a tomboy or is simply flamboyant, or might grow up to be a homosexual. Complicated notions of gender identity are common in childhood, but a real disorder or dysmorphia is different. Parents in some developed countries where the diagnosis is commonly being made often have to make a decision whether to have an unhappy child who is a boy but feels like a girl, or to have a happy child who becomes the gender they think they really are, but with any attendant risks involved. The issue has sparked a discussion about whether children, especially pre-puberty ones, are capable of understanding the complexities of gender, fertility, and sex. Questions over whether patients and doctors should help children down a medical path they might later regret. Over the appropriate age for puberty blocking treatments, which are physically reversible, and whether parents should deny treatment with the consequences of possible severe taunting and bullying occurring at school, or instead trust a child who says their biological sex is causing unbearable stress. Data from one practitioner indicates that roughly 15% of children who have gender identity issues at a young age persist with a full-blown disorder or dysmorphia later in life. Researchers do not know as yet whether young children whose parents allow cross-dressing and other gender-bending behaviors are more likely to seek sex change and treatment when they get older. Should parents seek to provide a social transition earlier on, before the child's outcome is known, or not? There is as yet no evidence that one approach is more harmful or more helpful. However, the research study in the journal Pediatrics found that young children who became adamant at puberty rarely changed their minds about switching sexes. An international committee of involved experts in the area of intersex stated that expertise in this field was lacking, and that for decades, overall clinical and social definitions of intersex were typically inconsistent. Its medical classification was inadequate, and clinical assessments and interventions varied dramatically from medical clinic to medical clinic. This variation also occurred in gender dysmorphia. As a clinical entity, gender dysphoria has also suffered from inconsistent definitions and inadequate classification. And so, there is a legitimate debate around the issue of sex change and transgender issues, and the degree to which members of society should use medicine to change their gender. At this interface, issues of sex and individual rights and freedoms, the welfare of children, and our duty to protect them before they cross the threshold into adulthood, and the making of life's major decisions all become flashpoints. We should, however, be cognizant that the Office of United Nations High Commissioner for Human Rights, which has the unique mandate of United Nations to promote and protect all human rights for all people, has stated that the eradication of gender stereotypes is critical to preventing human rights violations based on gender identity. And so, we come back to the question of different ways of seeing. And what do we see when we look? We should recognize that we are all human beings looking for information and understanding. Hopefully, we can see our society and the wider world a bit differently and with more insight than we did before we began this webinar. I thank you for your kind attention.
I'd like to use this opportunity to thank our distinguished guest speaker for a brilliant dissertation on a very complex and controversial issue. I anticipate that you have left many of us with very unpleasant foods for thought. And I will not invite any questions yet, because I'll be interposing my own thoughts on this matter, and then we'll have a brief interaction with the audience about many of the issues that you raised. Excellent presentation, Derek, well thought out, and well presented. I'd now like us to pause for a moment to see if the AGPJ president is able to join us to share his thoughts with us and then to introduce the panelists. Dr. Gordon, are you online? Apparently, yes. Yes, Dr. Gordon, over to you for a brief comments and to introduce the panelists.
Dr. Gordon, over to you, Doc.
Me?
Yes, sir.
Yes, go ahead, Dr. Gordon.
Doc, let's stop your video and see if that helps with the bandwidth. Audio-wise, can you hear us? Dr. Gordon?
Hello, Sam.
Hi, Doc. Nice to hear your voice. We can hear you. Can you go ahead and deliver your welcome remarks? We can hear you clearly.
First of all, my apologies for my internet charge.
Sam, under the circumstances, perhaps we should.
Agreed with you, Prof. Definitely having really challenging internet issues there. Apologies to our attendees and apologies for Dr. Gordon. I really know how much work he put into this amazing evening, which had an amazing presenter so far. So, Prof, we'll go over to you. I'll try to speak with him again on the other end and see what options we have to get him to deliver his remarks.
No problem. Colleagues, it's indeed a pleasure to be part of this discussion, and I anticipate that what I'll do over the next few minutes is to essentially help to clarify some of the issues which Dr. Aarons raised. Sam, I'm trying to get into share screen. I'm not too sure what's happening. No, I'm on. Can you see my screen?
Yeah, I can see your screen. I think what you're trying to do is go into your slideshow. So what I'll ask you to do, there you go. That's it. Click on that one there.
I'm on. Excellent.
Yeah, there you go. Perfect.
Colleagues, Dr. Aarons have just presented an excellent dissertation on the complexity of ethics and gender. What I intend to do over the next 5 minutes or so is to just add some color to his discussion by reminding you, as he mentioned, that gender is a social construct that categorizes and labels societal and cultural expectation for how people of different assigned sexes are supposed, and the operative word is supposed to act. But Dr. Aarons remind you that gender varies over time and from place to place. These are two persons who are the same, a man, a trans man, and a trans woman. But I want to introduce a term called gender binary, which refers to the societal or cultural belief that there are only two categories of gender, men and women. So this slide shows you, and these pictures are taken from the public space. This is the picture of a man who opted to become a woman. Non-binary describes any gender identity which does not fit the male and female binary spectrum. So here you have an individual that is displaying gender fluidity. On my left is a female, and on my right is a male. On my left is a male, and on my right, he opted to become a female. So the relativity of gender identity makes absolute statements about identity development quite impossible, as Dr. Aaron pointed out. Here to my left is a male who opted to become a female. I want to introduce you now to some brief statistics which would emphasize the concepts that Dr. Aaron's raised. The concept of LGBTQ+. This stands for lesbian, gay, bisexual, and transgender. This was introduced in the 1990s and is generally used to include anyone who is not heterosexual or cisgender. To my left is a woman who opted on the right to become a man. I thought this slide was quite interesting and should provide for you all some interesting food for thought. Where do you find the most LGBT persons in the world? Contrary to popular belief, it is not the United States, where the prevalence is 10%. And in 30-country average, the prevalence was 9%. This suggests to me, colleagues, that in most countries of the world, 1 in every 10 persons are LGBT. And of course, you'll notice from the slide that the majority were found in Brazil and the least in Peru. What I found particularly interesting and would enhance the quality of the discussion is a change in attitude of persons over the years. Look at the traditionalists, our grandparents, who were born before 1946. Look at the baby bloomers, Dr. Aarons and myself, who were born between 1946 and 1964. Look at Generation X, born between 1965 to 1980. And then we move to the millennials, 1981 to 1986. And this rather interesting group of persons, Generation Z, 1997 to 2004. But this slide is quite interesting that Generation Z has a complete different perception of sexuality than the baby bloomers, myself and Dr. Aarons, or my parents, the traditionalists. Very interesting indeed. Now, Wallace presents gender identity of 1 in 4 spectrum. He talks about sex, which refers to a person's genitalia and secondary sexual characteristic. So each person is born with either male or female genitalia or a combination of both, called intersex. But the issue that evokes the most emotion and controversy is the concept of gender identity, where this represents a person's core sense of being male or female or within a continuum. So look carefully at this picture in the public domain with a gentleman on the left who chose to become a woman, and they seem to be quite similar in facial characteristic, minus the beard and the long hair. So Carl Gilroy argues that transgenders represent a wide variety of expressions and identification that significantly differ from individual birth assigned or natal genders. I thought I'd share this picture with you because it indicates the wide continuum of gender characteristics, male, female, asexual, androgyne, neutrons by gender, demi-boy, demi-girl, intergender, genderqueer, agender, and so on. The spectrum is vast. What about gender expression? This has to do with the clothing you wear, your parents, speech patterns, and demeanor. So this person is actually a man. What about sexual orientation? Well, it refers to the sex or sexes to whom a person is sexually or otherwise attracted. I thought I would like to introduce you to the concept of gender pronouns. And this is important because I'm going to give you an MCQ in about a minute or so, in which you're going to reflect seriously on gender pronouns. Natal females who identify themselves as males call themselves he. And natal males who identify themselves as females call themselves she. But Leslie Feinberg in 1998 argues that there should be a third gender pronoun. It's spelled as SIE, but it is pronounced as C, and HIR, which is pronounced as here. Very interesting. Take a look at this slide, colleagues. As you can see at the top are the normal pronouns she, her, and herself, him, and himself. What do you call someone who decides to call himself herself, or herself, or herself? Do we accept that as his representation of his own reality, or do we frown upon that kind of autonomy? So I'm going to invite you, Sam, to show the first slide with the poll, which is a case study in which you're going to be invited to vote. So I'm going to stop sharing, Sam, and then it's over to you.
Okay, no problem. All right,
You'll be given 60 seconds to make a choice.
All right, so an outpatient psychiatrist.
So do you have, okay, that's the poll. Okay, go ahead, Sam.
All right, so what is the best response to?
No, you have not asked the question.
Oh, sorry, let me go ahead, yes.
Yeah.
An outpatient psychiatrist encounters the mother of one of his patients in the hallway of the clinic. The patient, a 19-year-old male who identifies as gay, had previously come out to his psychiatrist. At his last appointment, he shared he was thinking of coming out to his parents as well. The mother, visibly irritated, corners the psychiatrist in the hallway and begins to ask him numerous questions regarding her son's psychiatric treatment. Apologies. After responding that he is unable to answer questions about the patient's direct care, the psychiatrist is then asked about the neuropsychiatric basis for homosexuality. This is case 1. What is the best response to the mother's question? Is it A, discuss different brain MRI findings between patients who identify as LGBTQ+, and those who identify as heterosexual? B, listen to the mothers and outcomes. I won't read this to you because you have 60 seconds. The poll will actually launch with the answer option. So let us launch the poll now. So please go ahead. What is the best response to the mother's question? You'll see them there. Ask the mother to come with her son and family. State that there is no established biological basis, etc. You have 45 seconds remaining. Prof. Bailey, you have an input there?
That's fine, Sam. The question is posted. The attendees is invited to make a choice.
Yes.
And then you will show the graph, and then subsequently you move to case 2, and then I'll have my discussion.
Perfect. We're 40 seconds into this one. 60 seconds is your full time. You have approximately 17 seconds to go. All right. Remember, we have 1,000 plus of you here. Thank you so much for joining. So far, we only have 35% participation, and we are indeed looking at participation for the CMEs that the Agpj and Medimpex have come together to provide with you tonight. So please participate using the poll. See the numbers rising. We're now at about 42%. You have 5 seconds remaining. All right, so we end that poll. The results for that poll are shared currently. Some 65% of our respondees said listen to the mother's concerns and encourage her to have a discussion with her son in an effort to better understand his needs. 24%.
That would be answer B.
Yes, that was answer B, correct.
And the response is 65% chose B.
65% chose B.
Okay.
And then we have 24% choosing E, which is ask the mother to come with her son and family. Sorry, I switched it by accident. Yes, ask the mother to come with her son and family to next week's appointment to facilitate a family discussion on the topic. So those are the two highest selected answers. 65% for B, 24% for E.
Thank you, Sam. Please move on to case 2.
Will do, will do. So for case 2, we see it on the board here. Julia, a 22-year-old trans feminine patient with a psychiatric history of bipolar disorder, follows up with a psychiatry clinic after a recent hospitalization for a manic episode. After discussing further changes in her medication doses, the patient visit wraps up and she's scheduled to have a follow-up clinical appointment in 1 week. After Julia checks out of the clinic, she notices that male pronouns are used in the automated post-clinic visit summary provided to her by the front desk clerk. Your poll, therefore, is asking, which of the interventions is least likely to improve the patient's likelihood of returning to the clinic? So again, the least likely, and it's in bold for a reason. And here we go. And these are your
The
choices.
participation is greater this time. Choose the least likely in this pool.
Yes.
And
So again, some 996 persons right now we have online. We're asking for your participation. So far, so good. We have 30 seconds remaining, and we have not yet had 10% of you replied. Please. So A, create a gender identity category in the demographics section of the electronic medical record. B, post materials and resources for the clinic that are LGBTQ plus friendly. C, use gender neutral language in the post-clinic visit summary. D, offer the patient an opportunity to switch providers at the same clinic. Or E, ask the clinic's leadership to offer LGBTQ plus allyship training.
how many seconds to go, Sam?
5 seconds, Prof.
Okay.
About 45% participated. That ends the poll. The results are in. D, offer the patient an opportunity to switch providers. Got 48% of the replies. And in a close second were both A and C with 17%.
Just repeat that for me, Sam.
So
48%.
second,
48%.
48% of the respondents selected D.
Yes.
And 17%, or I should say 34% collectively, split down the middle, 17 and 17, selected A and C.
Okay, thanks much. Okay, I'll now have a brief discussion on the response. Could you
Right, let me
just
stop my sharing so you can share. Go ahead.
Okay, colleagues. So for case 1, the answer was B. This case illustrates several ethical principles, and after I've completed my discussion, I'd like to invite Dr. Aarons if he would like to add his thoughts to this issue. This case illustrates several ethical issues, including beneficence, which is to ensure a harmonious relationship between the patient and his parents. It illustrates non-maleficence, that is, avoiding reinforcing the mother's distraction from providing adequate support to her son with unproductive questions regarding his sexuality. It also addresses the ethical principle of privacy, protecting private patient health information from his mother, and veracity or truthfulness, answering the mother's challenging questions truthfully while respecting the boundaries of the patient's personal life. It seems, therefore, colleagues, that the mother is preoccupied with her son's sexuality, perhaps out of a hope that he will change. Her attitude is not uncommonly experienced by those in this population. Inability to accept a family member's sexuality can have important negative consequences, as patients who identify as gay, lesbian, or bisexual are at increased risk of suicide, lack of social support, acceptance and understanding from close relationships. Please note that conversations focused on the biology of homosexuality can serve as distraction from helping families understand what they find unacceptable. However, in 2019, a paper published in the textbook, an article in the textbook of psychiatry by Drescher et al. Argues that the causes of homosexuality, bisexuality, and gender identities are unknown. Therefore, speculation about their origin may be unfruitful. Beneficence therefore ultimately guides culturally and structurally competent physicians like yourselves to ensure optimal care of LGBTQ patients and the potential interpersonal precipitating or perpetuating factors in a patient's psychiatric symptoms. Therefore, gaining a clear understanding of the family's underlying concerns and encouraging a similar effort on their behalf to understand their child's struggles is an important first step toward facilitating a safe and supportive environment. With respect to case 2, the question was which of the interventions is least likely to improve the patient's likelihood of returning to the clinic, and the answer is D, which is the least useful thing you could do is to switch providers in this case. And the argument is that many physicians will work with transgender or non-binary persons at some point in their careers. Although studies have shown that roughly 1 million adults in the States identify as transgender, this may be an underestimate. It is important for the team, especially the mental health team, to effectively advocate for the patient because of the health inequities that the LGBTQ community faces. You need to remember that transgender non-binary adults are more likely to experience serious psychological distress and thoughts of suicide. Transgender patients are subject to acts of violence, harassment, and discrimination. If LGBTQ patients receive mental health in a non-friendly environment, they might terminate their relationship with you. Therefore, I argue, and Dr. Abrams would agree, that affirming a patient's identity is important in any therapeutic relationship, and it is important in the care of these patients if providers uphold the ethical principle of justice, fairness, and equality in their practice. Therefore, Dr. Aarons argued that we need to think carefully about respecting the autonomy of transgender persons who ask us to consider providing for them fully reversible intervention, partially reversible intervention, or irreversible intervention, and we discussed that in great detail. I saw this article that I thought was interesting, that the Harry Benjamin International Gender Dysphoria Association has apparently established medical and mental health protocols for transgenders who seek hormonal and surgical sexual reassignment. This is the end of my presentation. Thank you very much. The floor is now open for questions, and I'll go immediately to the question and answer section. But Dr. Aarons, what are your thoughts about the two cases?
Thank you, Professor Bailey. And I was heartened by two main points. One, you touched on many of the ethical issues to be considered in both of the cases. And the second point is I was particularly impressed by the responses of the audience, because in both cases, the majority choice was what I considered to be the correct choice. And so it means that all persons in the audience are sensitive to these issues and are more likely to make the right choice when confronted with these challenges. And so I commend you and the audience for the last 10 minutes in your presentation, the cases you selected, and the responses that they gave. Hats off to you all.
Thank you very much, Dr. Aarons. A question that I see here is, how do you differ homosexuality from gender identity issues. What are your thoughts?
They are not different. Gender identity speaks to self-identification. And then from the identification, then gender expression may be expressed in a way that reflects sexuality or sexual encounters. So that is where the concept has to be clear. The person identifies how they perceive themselves, and then they act in keeping with the way they wish to. So we should not confuse the issue. We should ask them to clarify how they perceive themselves and what are their sexual attractions. We use the term sexual orientations, but they are the ones who would identify who they're oriented or attracted to, whether it be a person of similar gender, of opposite gender, or a combination. And as we have seen in the presentations that I've given, as well as that which Professor Bailey has illustrated, the combinations can be wide. Sure, we know in our discussions, certainly in the Jamaican society, we often think of just binary and a combination across the two. But from the diagrams we were shown, the combinations can be very vast. And so we have to be aware of the vastness of it, as well as asking individuals to identify their own perceptions and where they wish to advance themselves or orient themselves. We have to get that clear. And so this idea of dichotomy doesn't really exist in real life. Much as many of us may have been oriented that way, and I shouldn't say much of society, because as we have seen from Professor Bailey's charts, that it varies across the world how each society allows people to express themselves. Some, using laws, have suppressed their populations, and so the dichotomy that the society places on their inhabitants is maintained. You're either a man or a woman. Others allow more humanitarian expressions. And so within that society, you'll find the various combinations coming to light, coming to awareness, coming to discussion, coming to manifestations of expression within the society. And so thanks for raising all those issues, Professor Bailey. And I'm also glad to be able to have simulated thought on this matter, as well as increase awareness of the wide diversity that exists within each society, whether it is suppressed or not, it exists. It is for us now to use our increased understanding to engage others and to dialogue in a more humanistic way with others on this very important issue.
Thank you very much, Dr. Evans. I just want to remind the audience that we have 10 minutes remaining for question and answers. Therefore, please post your question in the Q&A section, not in the chat. Next question, Dr. Evans, is there a correlation between the level of sex hormones and gender dysphoria in affected individuals?
The research is going on in that area. And as I said as a part of my presentation, the answers are not yet clear. As we know, those of us who are scientists, because we know we have laypersons in the audience, those of us who are medical scientists will know that research can provide a collaboration, but you can't be definitive until all the variables align themselves to answer distinctly yes or no. So research has shown there is collaboration, coordination, and possibly association. But as yet, and please be aware, research is still going on. As we all know, all around the world, people are doing their PhDs, and studies in this area is bringing out new knowledge. More clinical, empirical research is being done. So 5 years from now, we'll know a lot more than we currently do. 10 years from now, we may have all the answers because we're doing empiric research. Human Genome Project started it, but gene combinations and the way they interact is a specialized area of study that is going on as we speak. And so more answers will come out in the publications that will follow over the years.
Thank you, Derek. Well, I have an interesting question here from one of our attendees. She was quite impressed with the second question because she's concerned that given what obtains in our Jamaican society, what obtains with documentation in medical records when legally we do not acknowledge any other sexes beside male and female. We may respect patient gender identification, but what we put on our documentation. What do you think, Dr. Aarons?
Which is why we're seeking to sensitize all persons that hold policy-making positions that it is time now to lobby to bring, certainly in Jamaica, bring our healthcare system in keeping with what is existing in countries of the developed world. I quoted from, for instance, Australia, changing their laws to recognize that gender is not just a duality. Our laws, our healthcare laws in Jamaica, likewise, need to be updated to reflect that this exists in fact. And respect for persons require that they not be marginalized or stigmatized or discriminated against, that their actual gender expression, which is a part of their own identity, be recognized when they attend our healthcare institutions.
Thank you, Derek. This question is a little challenging. One of the audience is saying, if a transgender person is born the way they are, why is it important for a physician to affirm something that is natural? That's a tough question.
Yes. The simple answer, it is not. In an ideal world, what would happen is that the individual would assert what they are, and we in the healthcare system would fit in with that assertion. The challenge, however, is when it occurs in childhood, where they are not yet legal entities to make such decisions. And so it's their parents that will guide the issue. And that is why, as a part of my presentation, I said we also have to question the parents' motives. Are they doing something out of shame within their community, or are they doing it out of concern for the future of their child? All of these are important considerations because these are all ethical issues. We know ethics is how do we interact with each other, how do we treat each other, how do we respect each other? And so these are important considerations. And we have started the process here. We will carry it forward as we discuss and seek to inform others and dialogue with others to bring about meaningful change.
This question is very provocative, Dr. Aarons. Let me see how you respond to this one. How do you distinguish between someone who genuinely feels like another sex versus someone who conveniently chooses to identify as a different gender?
That is simple. One, it's like saying, no, I shouldn't use this example because that one interfaces with law. But what it really is, as long as that person is not committing a crime, whether they are acting to be or whether they genuinely believe they are, doesn't matter, shouldn't matter. How we interact with them should be as human beings. What is their sex or gender should not matter. We respect them, we respect their wishes, and as long as they're not infringing on our rights, then we have the obligation to treat them as equal members of society.
Okay, thanks, sir. Another question. how would you advise parents know how to socialize their children younger than 12 years based on gender identity?
We touched on it as a part of the presentation. You have to allow the child to express themselves as they grow. You need not do anything about it until puberty sets in. However, ensure that you are in dialogue with a health professional and also a mental health professional. At puberty, this is where we make the decision. If the child continues to strongly express a desire to be of a sex that is opposite to the way they have been perceived to be at birth, then that is when, in consultation with the specialist, because it really involves whether it be a pediatric endocrinologist or a specialist in sex therapy, along with mental health, they're all a part of the healthcare team that will make a decision whether puberty blocking treatment commences then to allow a further 4 years, assuming puberty kicks in at age 12, it could be 10. But we want to delay puberty, which is going to anatomically masculinize or feminize that person if it is opposite to the way they wish to be. So you delay that until age 16 to give them time to think, to feel, to be convinced that this is the way they want to be permanently. And then at age 16 years, you complete the treatment in accordance with what the person over the last 4, 5, 6 years has maintained what they wish to be as teenagers.
Dr. Evans, thanks very much. We run out of time. This particular question seemed to be worrying the audience. The question of gender identity on request forms. This participant said there are certain diagnoses that are dependent on sex. Lab results that are based on sex and hence must either be male or female, and such is indicated quite often on the report or result. Is that now an issue if you identify a male as a female and vice versa? What are your thoughts? Final question.
Yes, and I agree. We are hoping out of today's webinar that we will seek to change the forms that are reflecting a simple duality, because not just is there a spectrum of all human characteristics, it's not just, and we all as healthcare professionals, we know this, there's a wide variation between male and female, but there are combinations in between of all the various factors that make us human. And this is no different with the endocrine system. This is no different with this is, sorry, there was a disturbance in my background that I was getting a feedback. Yeah, the measurements, and many of us here have to be reading the chemicals that exist within our bodies and the measurements that are regarded as being normal and abnormal. And these may vary for male and female, but they also will vary for persons that are intersex, that have combinations and variations. And what we're doing here today is to start the discussion, to effect change, to bring our scientific approach up to where science has advanced and identified that this reality exists. The science that we practiced 20 years ago that simply worked on duality now needs to be updated to reflect what research, scientific research, has brought to our awareness that there is a continuum, a spectrum that has to be considered.
Thank you very much, Dr. Evans. Sam, I gather you want one person to ask a question live?
Yes, Prof. I think we could allow it if you're okay with it.
Just a quick question and then we'll have to
Sure.
move on.
Robin Stevenson, you have been selected. Please unmute. Robin Stevenson, quick question.
Hi, good evening.
Hi, good evening.
Thank you so much for this webinar. I think it's important. I think you're stimulating a lot of the discussion. I actually had glimpsed this on one of your slides, and I don't think you presented it, and I saw some comments about it in the chat. But where do you come down on the responsibility, the ethical responsibility of us as healthcare practitioners to examine our own personal biases and updating or improving our biases versus referring patients out to other providers? Where do you come down on that dichotomy?
Thanks for that very important question. And I think you provided the answer somewhere in there, because remember, as healthcare professionals, we're not looking after ourselves. We're looking after others, our patients. And so we should always be willing to not only listen to them, but to refer them to persons if we are unable to provide the care that they need. And so that is a guiding principle we should always use. We are aware, all of us have biases. All of us have been socialized as to be prejudiced. I shouldn't say all of us. Many of us have been biased in our upbringing to reflect badly on certain people. And we have to be aware of our biases and not let our personal views of individuals determine how we interact with them in the healthcare setting. And if we feel we are not able to provide them 100% healthcare service, then we should refer them to someone that we think might be able to help them more. And it applies not just in this issue of gender and sexuality, but in all the various forms of presentation that come to us in the healthcare setting. Be willing to refer where we feel that we may not be offering the best that is possible in terms of healthcare and advice that we provide to persons.
Thank you very much, Dr. Aarons. This section of the webinar has come to an end. It has been quite a revealing discussion. I did say at the beginning that some persons might be very uncomfortable with the topic, and based on the response from the chat, we can see that some discomfort has been experienced, which is understandable. It is definitely an opportunity for us to do some introspection and decide, as you said, Derek, that we are dealing with our patients, not ourselves, and that we need to recognize that we're all human beings. And the question of autonomy, beneficence, non-malfeasance, and justice is always paramount in ethical practice. Thank you again, Dr. Aarons, for a brilliant dissertation. I will look forward again to see you next year at another annual ethics seminar. Thanks very much and Godspeed. Ladies and gentlemen, we now move to the next section in our presentation, which is a sponsor's presentation by Ms. Sasha Dixon, medical representative. I trust that you are ready to provide us with your presentation, Ms. Dixon.
Greetings. Thank you for having Medimpex Jamaica here today, showcasing to you just a few of our products which are geared towards mental health treatments. Here we have Stimuloton, which is our brand of sertraline. It is in a 50 mg presentation, and Stimuloton is a selective serotonin reuptake inhibitor. Now, what is the mechanism of action of Stimuloton? Stimuloton acts within the brain to increase the amount of the neurotransmitter serotonin in the synaptic gap by inhibiting its reuptake. This helps to ease the symptoms of mood disorders such as depression and anxiety. Stimuloton is used to treat depression, panic attacks, and obsessive-compulsive disorders. Stimuloton is the first choice treatment for depression because of its excellent efficacy, safety profile, side effect profile, and the onset of action. How do you use Stimuloton? Now, in terms of depression and OCD, It requires a 50 mg once daily, taken with food. Complete therapeutic effects can be seen after 2 to 4 weeks. For panic disorders, in the first week, 25 mg is taken once daily with food. In the second week, we upgrade now to 50 mg once daily, also taken with food. And complete therapeutic effects can be seen after 8 to 12 weeks. Maximum daily dosage is 200 mg. Stimulation can be used off-label for treating premature ejaculation. The dosage, 50 mg once daily for 6 weeks, thereafter when needed. As prophylaxis, 50 mg PRN 2 hours prior to sexual intercourse. Dosage adjustment for special populations. For Stimulation, while in the elderly, no dose reduction is required. Renal impairment, no modification of dose is necessary. Hepatic impairment, a lower dose or the usual dose with longer dosage intervals. For pregnancy, safety has not been established, and also in nursing, it can be excreted in breast milk. So what are the benefits of Stimulation? Stimulation is among the most potent SSRIs. Age has no influence on the clearance of Stimulation. Plasma levels and clearance can be quickly and effectively controlled, and there is a smaller effect on the CYP proteins, thus reducing drug reactions. Stimulation, offering choice to your patients. Stimulation retails at approximately $140 per tablet. NHF subsidy for this drug is $45 per tablet, and the patient will pay approximately $95 per tablet after NHF coverage. Stimulation lifts you out of depression. Next, I present to you Palixid, which is our brand of donepezil hydrochloride offered to you in a 5 mg and 10 mg strength. There are many different forms of dementia, with most common being Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia, and Parkinson's disease dementia. Alzheimer's is one of the most common causes of dementia. The term dementia describes a set of symptoms which can include loss of memory, mood changes, and problems with communication and reasoning. These symptoms occur when the brain is damaged by certain diseases and conditions, including Alzheimer's disease. People with Alzheimer's also have a shortage of some important chemicals in their brain. These chemicals are involved in the transmission of messages within the brain. Alzheimer's is a progressive disease, which means that gradually over time, more parts of the brain are damaged. As this happens, the symptoms become more severe. What are the top 10 warning signs? Recent memory loss affecting job, difficulty performing familiar tasks, problems with language, disorientation to time or place, poor or decreased judgment, problems with abstract thinking, misplacing things, changes in mood or behavior, changes in personality, loss of initiative. Alzheimer's disease is characterized by two abnormalities in the brain, the formation of amyloid plaques between the nerve cells and neurofibrillary tangles within the neurons. Here we're showing the characteristic signs of Alzheimer's disease found at autopsy. On the left is a normal brain, and on the right is an Alzheimer's brain, which shows the neurofibrillary tangles and amyloid plaque formation in the brain. Palixid is indicated for the treatment of mild to moderately severe Alzheimer's disease. So how does Palixid work? Palixid is a cholinesterase inhibitor. It is a specific and reversible inhibitor of acetylcholinesterase, which is the predominant cholinesterase in the brain. Donepezil hydrochloride is postulated to exert its therapeutic effect by enhancing cholinergic function through increased concentrations of acetylcholine. There is no evidence that donepezil alters the course of the underlying dementing process. It just slows down the progression of the disease. Now, how do we administer Palixid? The initial dose is 5 mg once per day in the evening before retiring at night for at least 1 month. After a 1-month assessment, the dose may be increased to 10 mg, and the maximum daily dose allowed is 10 mg. For your renal and hepatic impaired patients, there needs to be no adjustment to the dosing as the clearance of the drug is not affected. Palixid is also not recommended in children. Palixid is offered in a 5 mg and 10 mg strength of 28 round white biconcave film-coated tablets. They are within the price range of $10,000 to $11,000 in the pharmacies. A few adverse effects that we can look out for Palixid is bradycardia, GI, muscle cramps, and fatigue. So why Palixid for your patient? Because Palixid is well tolerated, improves cognition and functioning, there's a 38% reduction in functional decline, and Palixid improves behavioral symptoms. Thank you for your attention, and please enjoy the rest of your evening.
Thank you so much for that, Sasha. I know Sasha was online. I'm not sure if she'd like to say something to support that live as well. No? Okay. Over to you, Prof. Bailey.
Okay,
Or
thank you very
Deji.
much.
Okay, well, thank you for listening.
Okay.
Thank you very much. And now, colleagues, we move to the final session for this evening, a session that, based on the responses saw in the chat and question and session, is definitely needed. You see, I knew that this particular presentation would have left many doctors a little confused, a little worried, and perturbed about the fact that now we talk about male and female, and then we talk about non-specific, indeterminate, unspecific, intersex. A lot of doctors are experiencing a stressful life moment. And so we need some time to rest, to recover, and to repair. So we have with us an eminent colleague who is going to have a talk with us about how we can effectively heal ourselves. And I think a medical representative has volunteered to introduce Dr. Richards. Do we have the medical rep online, Sam?
Yes, I do. It's Mrs. Cheyenne McGrew. She will open her microphone now to do so.
Could you go ahead and introduce Dr. Richards to us?
Good evening, everyone. It is my distinct honor to introduce our second speaker for this evening. She's a consultant psychiatrist for the University Health Services at the University of the West Indies Mona campus, as well as an adjunct lecturer at the Department of Community Health and Psychiatry. She was medically trained at the Faculty of Medicine, UWI Mona, between 1997 and 2009, where she completed her MBBS degree as well as her DM in psychiatry. She also completed a certificate course in infant and early childhood mental health in May of this year at Georgetown University. With over 2 decades in the field, her journey as a psychiatric expert has been nothing short of remarkable. What sets her apart is her deep passion for guiding, empowering, and inspiring patients as they navigate the challenges of living with severe psychiatric conditions, all while confronting fear and stigma with courage. Please join me in giving a warm welcome to our incredible speaker who continues to make an invaluable impact on mental health and well-being within the academic community and beyond. Dr. Nyameke Richards.
Thank you so very much for that wonderful introduction, Cheyenne. And thank you so much to all the attendees this evening. It's lovely to see the numbers present for these presentations. Thanks to the Agpj for inviting me along with Medimpex. led by Paul Dennis and the team, for inviting me to be a part of this extraordinary webinar. I want to start by saying that there's so many parallels between this talk about, attending to the human rights of persons based on their gender identity and sexual orientation with mental illness and patients, living with mental illness. And I just hope that, whatever efforts we make in either, that we'll make better efforts in both directions, and that we will also make sure to treat mental illness and the mentally ill with as much respect and for their rights as people, just as we would anybody else, regardless of their gender identity and sexual orientation. So let's not leave out, the discussion around the mentally ill. And as Dr. Aaron said, this matter of concept matters. I'll just tag mental health matters as well, all right? And as you can see, I'm a mental health advocate and coach. So advocacy is very important to the work that I do, and I'm very passionate about that. As Cheyenne said, I'm the UA psychiatrist at the Mona campus. In fact, the only psychiatrist attached to all 5 campuses of the university. And my pronouns are she and her, in case you didn't notice. But I also respond to the I and I, the I in I and the I in all of us, and how we see each other as one, right? I'm also a daughter, mother, and carer. And of course, I float between earth, wind, fire, and water. Don't trouble me. All right, let me get going here. No, it's not. For some reason, it's not moving.
That's okay, just click on your PowerPoint and it should activate it.
So my topic today is time for rest, recovery, and repair in primary care. I hope you saw what I did there. And, this idea of resting is so important. And I think it really should be an ethical issue. And it should be something that we pay great attention to, especially in the field of health. And generally, as workers, professionals, in everything we do, we must make time for rest. And with that said, I'll just add that if you find yourself being a little sleepy, is when I touch this head. If you find yourself being a little sleepy, I don't mind. Feel free. If you fall asleep, just don't snore. There was one session where we had some snoring going on some time ago during COVID. So please don't do that to me. I beg you. All right. So a little about me. As I said, I'm daughter, mother, and carer. My psychiatric training was grounded in a post-colonial, Afro-Caribbean, and culturally relevant epistemology, which began at the feet of the late, great Jamaican scholar and my professor of psychiatry, Dr. Frederick W.E. Hicklin, whom many of you would know. I am deeply inspired and propelled by the service of the late, great Doctors Janet Lagrenade, as well as the late Doctors Charles Thesiger, Franklin Otti, Franklin Lahey, whose seat I fill at the health center, and of course, Dr. Ivani Bailey Davidson, who many of you would have, known, worked with, rubbed shoulders with, and of course, laughed with. As university psychiatrist located at UA Mona campus, I single-handedly work with students and faculty members to diagnose and treat mental health disorders. I provide a person-centered approach while offering supportive talk therapy in the promotion of mental health awareness through an anti-stigma lens. My work includes training workshops and referrals to other mental health professionals or resources in and around the UA community. And this is a little bit of what I do on campus. We do IG lives, Instagram lives, a lot of training sessions and mental health education sessions. And we also supervise our 24-hour, what we call a lifeline, but you'll all know it as a helpline, among so many other things, My professional passions. mental health education toward reduction of mental health stigma and discrimination, sexual and reproductive health rights, equal rights and justice for all, Afro-Caribbean identity consciousness, and of course, the recognition and respect for non-dominant bodies of knowledge and therapies as well. Attending to the mental health needs of an individual goes way beyond assessing and managing their thoughts, emotions, and behavior. In fact, it requires an exhaustive exploration of the person's life from not only birth and in utero, but further to include the lifestyle practices and psychosocial practices of the person's immediate and distant relatives. Gaining this depth of knowledge across generations allows the clinician to participate in the transformation of the individual and the individual's family, with implications, of course, for rescuing the mental health of the nation. Very serious work. And this is my team of counselors that I work with very closely at the Health Center. You may recognize a few of them: Dr. Debbie Ann Chambers and Dr. Lester Shields, Ms. Tamaya Wilson and Dr. Jennifer Stewart Dixon over on the Western Jamaica campus. And then our newbies, Dr. Daniel Brown on top, and Dr. Craig McNally and Ms. Denise Boxhill. This is the team I work with on the campus. So we're gonna have a little fun. By typing in the chat, please show me what emoji would best describe your day today. Let's have a little fun with that and see what comes up at this time. I'm sure maybe a lot of tiredness, but I like the hearts. I like the thumbs ups and the laughs. I'm loving it. Wonderful, lots of hearts, I'm into that. Now, rest for recovery is really rest for survival, right? This is a survival story. Another element of group fun: where do you get rest? This is the question I'm asking tonight. Please post in the chat. Let me see what you come up with. Where do you get rest? I'm hearing when you die, but let's not wait till then. All right, not seeing anything in the chat at the moment, but okay, please share and keep sharing. So you will not move toward liberation from an exhausted state, right? We're not gonna get too far ahead if we're just exhausted and tired all the time. And this is a quote from Tricia Hershey, from her book, Rest is Resistance, which I'll quote quite a few times as we go through. One of her cards from her deck of cards regarding rest and resistance is, I will swaddle myself in rest. I will gather myself in rest. And some of the ways we can rest, which we can even consider rest as grounding. And some of the things we can do is a morning meditation practice. Repeat a simple mantra or affirmation. Be present with your meals. Go for a nature walk. And I mean, as simple as just looking at leaves, looking at a flower, you know, taking the picture of a flower you see, the grass, feeling it on your feet, at the sole of your feet, you know, just paying attention to these very simple things helps us to rest and to take a break, you know, and to pause for a bit. Soothing music, sip hot tea, a self-massage. If you can't get one done at a spa, you can actually do it for yourself. Just rub your little shoulders, rub your hands, rub your back, rub your neck, rub your head, you know, rub your hands, your fingers. Make exhales longer than the inhales. Now, when we talk about repair, I don't know how many of you are familiar with this Netflix feature, My Octopus Teacher. It was produced in 2020. It's a critically acclaimed 2020 original documentary film, which details the experiences of Craig Foster as he free dives in the cold underwater kelp forest near the Cape Peninsula in South Africa. It's a heartwarming look at the way a meaningful bond can transcend just about any barrier. And what it shows too is that octopuses are curious and clever. They can solve mazes and puzzles, use tools, and are masters of camouflage. In one attack upon this octopus, she loses an arm and retreats to her den to recover, slowly regenerating the arm over 3 months. In a later shark attack, she shows an incredibly improved creativity to survive. This is what an octopus is capable of. And this is a perfect demonstration of what we too need to be doing when we're dealing with trauma and the dangers of life. We too have this ability to recover, to retreat, to regenerate, right? Genetically in our DNA, so that we're better able to survive and mount the responses needed when other attacks come. Up to 80% of people will experience a diagnosable mental health condition over the course of their lifetime, whether they know it or not. But almost 60% of employees have never spoken to anyone at work about their mental health. Rates of depression and suicide among doctors are among the highest of any profession. But guess what? We're less likely to seek mental health care. And so we suffer in silence. And this is largely because of the culture of silence around mental health and the culture of mental health discrimination. The third largest number of students reporting to the University Counseling and Psychiatry Services at the Health Center are from the Faculty of Medical Sciences. Self-reported suicidal feelings are high, up to 44% for MBBS students, right? We are struggling as health professionals, and this has been happening before, during, and now with the pandemic. We're less likely to seek mental health care. We suffer in silence also because of the mental health stigma and discrimination, which impacts treatment-seeking behavior. We now need to normalize help seeking, normalize seeking mental health care, normalize taking time to rest, to adjust, to cope, to repair, to recover, to heal and care for ourselves. We do a lot of caring for others at home and of course on the job. When do we make the time to take care of ourselves? It can happen when we rest, and we must make time to rest. Rest is our right. Rest is necessary. Rest is survival. And as we kind of explore trauma a bit, I want to mention this. As doctors, we tend to look at the problem, we want to solve the problem. And we often refer to it as the presenting complaint, right? We're looking at what is wrong with the patient, what brings them to the office, okay? And what we need to really do is pay a lot of attention to the history of the presenting complaint and really start asking more about what happened to you on a deeper level, you know? That history that is often immersed in trauma, that history that dwells in, you know, at the home, on a domestic level, on a community level, that often is rooted in the way the person, the relationship they've had with their parents or caregivers. Those matters are areas that we do need to start paying attention to when we're looking at the history of the presenting complaint. This question actually grounds my professional inquiry of individuals on a journey of self-discovery towards excavating what lies underneath their turmoil, discomfort, and disease. Dis-ease, right? So when I look at what happened to us as a society, as a country, as a nation, as a people, we are low to middle income islanders. Dare I say captives. And we have been basically, captured and brought to this country under very traumatic circumstances. And we've still not yet gotten beyond that. And we can see that daily in the violence, in the crime, the level of abuse, in the aggression, the hostility that we see in the news, in our people, and even in the way we deal with each other, the way we deal with our children, the way we deal with the elderly, the way we deal with difference and people's differences, So we need to take a stock on that. We're a people with a history and culture framed before, during, and post-colonization and enslavement, with a history that shapes the present. The remnants of this harsh and oppressive traumatic past are embodied in the patriarchal institutions that govern health, education, economic growth, development, and the politics of today. It is the appreciation of this historical trauma perspective that must inform our rest, our recovery and repair practices. Healing practices collectively rooted in a tradition of Afro-Caribbean brilliance and wisdom, resilience and survival. So rest to repair, rest to recover, rest to heal, to live, to thrive, rest for survival. And some items that we can use in our traditional wisdom is drumming, music. We see where the VPA, the Violence Prevention Alliance, that's housed in the Child Protective Family Services Agency, have an initiative of drum therapy. We've also seen recently in the news that there is the use of art and other creative therapies that was launched at, I believe it was the Mustard Home for the girls. We can also do this in ecotherapy, as I mentioned earlier. In the rush of life, we tend to lose touch with the peace that is available in each moment. So I implore you to pause, take stock, take time to rest. Rest is survival, rest is repair, rest is necessary for living. And I'll end with this question. What's your favorite animal, not your family pet? And list 3 reasons why this animal is your favorite. And I'll see what comes up in the chat. And we'll talk about those responses. A list of a few of my references. And I just want to thank you for your indulgence. Thanks again for having me. And rest well. Some of the answers. Thank you so much. Thank you so much. Yeah, you're to give me the reasons why that's your favorite animal. So tell me, intelligent, calm, carefree, the dolphin. The dog, loving and faithful. Birds for their beauty. The dog is loving, cats loving, yes. And what this tells us, these terms, these descriptives that you've used are actually how you see and perceive yourself, right? How you see and perceive yourself. So let's celebrate that. Thank you again.
Thank you very much, Dr. Richards. You presented a very sobering, thought-provoking, and relevant dissertation on an issue which we tend to ignore. I actually found your presentation interesting because when I went to med school, long before you were born, a significant number of my colleagues had some major mental problem. And I emerged from med school with a thought which has remained with me most of my life, that if I survived med school and was mentally stable, then I'm okay. But unfortunately, many of the persons who entered my class in 1975 didn't survive and had mental issues. And the reluctance of us as doctors to admit our weaknesses and to reach out for help is profound. And so I really appreciate your very succinct and very sobering discussion on a topic that we need to take seriously. And we look forward to continue hearing from you. And I think the need for us to have regular sessions about mental health is paramount among physicians because we do need to take care of ourselves. It's now 8:45, and we do have some time for at least some questions. So the floor is now open for questions. And so I'll ask the first question, which said, do you agree that there's a myth of what we call normal? If so, why? Something is amiss in our society when it comes to mental health and treatment. That's a rather profound question, but
Could you repeat that?
The question says,
Which one?
is there a myth about what we call normal?
Is it?
It's the
I'm
myth.
seeing a question here. Is it possible that peer pressure or social media could be contributing?
Oh, actually,
Is that the question you were starting with?
No, so this the first
Dr.
question.
Bailey?
Let's go to the first question.
Can
Is
you
it
hear
possible-
me?
Yes, I can hear you quite well.
Is anybody hearing me?
Yeah, I can
All
hear
right.
you.
Doc, we're hearing you. I think what's happening is we're muted on your end. Are you hearing me?
I am.
Okay, great.
Okay.
So
First-
Prof was asking you a question from
Yeah.
an attendee, Janice Stewart. Do you agree that there's a myth of what we call normal? If so, why? Something seems amiss in our society when it comes to mental health and treatment.
Certainly. So I do believe that normal is a myth, if that's what Janice is suggesting. Because normal obviously is a spectrum, and even the person who is exhibiting mental symptoms, it is normal that if you understand their history and if you understand their genetics, and their situation and circumstance, it would be normal for anyone who is going through certain things to start to, have a certain kind of aggression or a certain kind of sadness or a certain kind of grief response. So a lot of what we might see as abnormal or extreme, when we think about the history and we look at the context, we can actually appreciate and understand where it's coming from. So in response to that part of the question, I'm not seeing the rest of the question or the rest of the point she was making about, how our society treats with mental illness. And I mean, we definitely see, live, and understand those realities. And we just hope that sessions like this to inform and educate and sensitize those of us in the field so that we then can impart this level of sensitivity to our patients, our relatives, and everyone that we meet, to kind of spread this message of normalizing mental health, normalizing help-seeking behavior, normalizing therapeutic interventions, normalizing rest, and taking leave, and being given enough leave when we, in our labor laws and all of that. Normalizing having a mental illness and taking medication and making sure that people have access to affordable medication. That's so very important from a policy level, from a political level, and from a health, professional level. I'm seeing some other questions. Should I just kind of go through, although they're running
Let me
fast?
just ask a follow-up question, Dr. Richard. One of Professor Abel's famous statement is that it's okay not to be okay. Many persons have found that statement almost like paradoxical, Expand on that. That it's okay not to be okay.
Right. And, of course, big up Professor Abel wherever I'm there. One of my mentors, and love him dearly as youngsters. Still consider myself a youngster in the field. It's okay to be okay, which is really about to not be okay. So, it is just really, re-emphasizing the point about it's normal if you're not feeling so well. It is normal to have bad days. It is normal to feel sad. It is normal to grieve. It is normal to be angry. And so too is it normal to have a psychotic response and to have a manic response. This is norm, right? This is a part of the reality that we live in. And we have to be more sensitive to those who are going through these sort of situations, especially when we can understand and appreciate the history and the context from which would generate certain sorts of responses and create the kind of stressors that would result in someone having some kind of, change or shift in their mental health, So it is in fact okay to be okay, but it's not just enough for us to say it's okay to be okay, but it's also important for us to make sure that our policies, our legislation recognize that this is normal and that mental illness is real and it is a medical condition that needs to be given due consideration and respect and access to proper health care, access to posts in public health, so that we have more psychiatrists, more psychologists, more social workers, more occupational therapists, staying in Jamaica, not leaving the country and migrating for greener pastures, but actually being able to stay in the country, live and work and serve our people who need this sort of intervention so much, as we can see daily in our statistics where crime and other ills are concerned.
Another question I want to ask you, Dr. Richards.
Yes.
In your CV, you emphasize creative and ecotherapy. Could you expand on that?
Certainly. So when we talk about creative therapies, which, and the ecotherapy, the creative therapies, as I showed in my last slide, we're looking at all the creative arts, from dance, drama, singing, learning a musical instrument such as drumming, any instrument at all, to ecotherapy, which now looks at how we use nature to heal, really, and how we use nature to be more mindful, and how we use nature to help us ground. Because a lot of times when we're having mental health symptoms or having stresses, our emotions become dysregulated, and what we do is that we need to learn how to self-regulate. And by using ecotherapy, using nature, using the creative arts, expending a lot of that energy through creative arts and through eco interventions, we're able to self-regulate better and cope better and even rest and repair and recover. So that's what it speaks to, in summary.
Give me some examples of ecotherapy. What do you do?
So an example would be, one of my slides showed a picture of a tree that's in front of the health center where I work. It's in bloom right now. And one of the exercises we recently did in a training session on ecotherapy was to kind of just take a walk outside of the health center, outside now onto the campus, and just look for something yellow. And so the picture I took was of the yellow bloom on the tree, and by just walking around through the grounds, through nature, looking around to find something yellow or find something heart-shaped, find something that feels a little rough, touch a leaf, smell a flower, simple things like that, walking barefoot, feeling the earth, feeling the grass, feeling the stones and pebbles, something that simple. You would be amazed at how healing just being more mindful, being more present can be. Even there's mindfulness even in how we eat and how we drink, having a sip of tea, you know, making a cup of tea, having it brew, sitting and watching the color change as it brews, you know, and just sipping it gently, slowly, softly, tasting it. You'd be amazed at how just allowing yourself to settle into these moments, appreciate them, recognize the joy in them, and giving thanks for them. You know, how healing that can be, you know?
Thank you very much. One last question then. Music. Music as therapy. What type of music would you recommend the doctors listen to
I
calm
am so
them down?
glad you asked. I have something queued up right here that we can maybe have a listen to. But I mean, our reggae music, of course. I mean, Barry's Hammond, Buju Banton. I mean, you know, Chronics, Janine, Protege,
Vibes Cartel.
Coffee. You know, I mean, this reggae song fest alone will give you a litany. I mean, don't get me started, Dr. Bailey. You know, and then we have the Afro beats. We have I mean, there are just so many, you know, Jamaica's Immaculate Symphony Orchestra, right? I mean, you just name them. I can't begin. You just find whatever you like to sing, whatever you like to dance, whatever you like to move, whatever you like to listen to. Just cue it up, you know, easy breezy, nice. But let me play the one I have. This one gonna put you to sleep though. This is actually one that I put my daughter to sleep to. I hope you'll be able to hear it. Let me see. Not sure if you're hearing me.
No, is it on your it's on a different computer?
It's on a different, is it too low?
It is. You want to tell me the song?
Yes, it's called Beautiful Chorus, called Inner Peace by Beautiful Chorus.
Inner
Dr.
Peace.
By
While,
Chorus.
while we're queuing that up, a
Yes.
concern was raised by one of the attendees. We still have 952, by the way. They're enthralled by your presentation.
Is that right?
They
I am
absolutely refuse to leave. Now,
Oh,
why are medical students so prone to mental challenges?
oh gosh. I tell you, let me, as a former medical student not too long ago myself, right? I mean, the rigors of med school, but even before you get to med school, the number of barriers and obstacles and challenges that one has to face and to overcome to even get a foot into med school, right? And then once you're there, you know, and then the cost of med school, and to maintain that cost every year alone would tell you a lot. But then, of course, from whence our students come, right? Their family lives, you know, the society, the community they're living in, what they themselves have been through, the rates of abuse in this country, sexual abuse alone, you know? And I could go on and on, Dr. Bailey. So med students are real people, as you know, and they come from this real country that sometimes don't feel so real, you know? And they come from real situations that do affect them deeply, you know, but their ability to come up and to enter med school shows their resilience, you know, and the power of one person who just cared about them, right? And then the pressure to perform and to meet the expectations of their families, of themselves, and the standards that they expect of themselves and that are expected of them, you know? So they come in, and then of course when they get to, on campus, the campus life, and then the independence and the boyfriend and the relationship and girlfriends and all the differences in personalities and identities and orientation and personality, all of that, it's a very delicate time in their lives as well, in terms of the phases of our development as human beings. So it's a very, very delicate time for an individual, and then of course for someone doing a course as rigorous as medicine, And so yeah, they come in, and the rates of suicidal feelings, depression, anxiety, performance anxiety, panic attacks, you name it, are pretty high.
Dr. Richards, I noticed that your topic is rest. Now, when I was a medical student, I never slept, which is true.
Thankfully, it doesn't show, Dr. Bailey.
Pardon?
I said, thankfully, it doesn't show that you never rested. It doesn't show.
Well, I don't know.
Tell us your secret.
I never rest because there was so much pressure for you to complete your various courses. Rest. How much time should one allow for rest in a 24-hour day?
Well, we know the scientific recommendations, depending on our stage of development varies. So as a baby, of course, we're expected to be really resting as babies and young toddlers for at least, 14, 15, 16 and upwards for the day. But as we get older, that time gets shorter and shorter. And on average for adults, we expect you to be getting at least 7 to 8 hours. Obviously, that may vary depending on your lifestyle, but ideally you want to be getting that 7 to 8 hour rest period in this stage of our lives, in this kind of middle adult years. And then as we get a little older, the numbers reduce even further, and on average we're saying at least 5 hours of sleep as you become more senior, more mature into your 60s, 70s, 80s and beyond, right? But what we don't do is we don't take naps, and that's the part that we probably need to kind of zoom in on, this idea of taking a nap. That siesta that our Latin American brothers and sisters do so naturally is something that we really should be doing more of, and so we should be we could be napping for 5, 10, 15, even 20 minutes, or up to even half an hour whenever we can, if it's at the desk, if it's at home, if it's just on your break. Just taking a nap, for a short little nap, is very good for our brains, very good for our energy, very good for our health.
How many naps per day?
I don't really know that statistic, but I'm just going from experience and from, what we know culturally and traditionally, is that we should, we can take 1, 2 naps for the day, but if you can even get 1 in, that would be nice. And as I said, it can be very short, 2 minutes, a little short eye, it goes a far way. And I know from experience.
Okay, thank you very much. It's now 10 minutes past.
See, Roshana wants to just sleep.
Roshana?
Just in the chat, Dr. Bailey. She said,
there is, Sam, do you have that restroom music that you wanted to share with us?
Yes, Mr. Sam.
Yes, let me find it. 1 second. Here it is.
Okay, folks, please listen to this and relax.
Me feel inner peace.
Enjoy.
At the center of me. Please let me feel inner peace from my center, at the center of me. Please let me feel the center of me. Please let me feel inner peace from my center at the center of me. My heart is open. I am aware. In me is a no.
All right.
I noticed that Dr. Richards was really having
Hope you liked it.
a good time. Thank you very much. Dr. Richards, we really appreciate your enthusiasm and the clarity of your presentation. You are a great communicator. I must tell you that Professor Hickson is also a personal friend and mentor. And I noticed that many of your expressions were actually from his famous statements. And it's obvious that you're an acorn from that famous oak tree. You've done well, and we definitely anticipate that we'll be hearing much more from you in the near future. I think, Sam, that Dr. Gordon wants to send his presentation to us. So thank you again, Dr. Richards, for an excellent, thought-provoking, and soothing presentation. Now, do we have Dr. Gordon's statement, Sam?
Yes, Prof. Let me get that for us right away.
Okay, thanks much.
Good evening, everyone. An apology once more for my internet issues. I am Dr. Gordon, President of the Association of General Practitioners of Jamaica. It is my pleasure to bring greetings on behalf of the association as we collaborate with Medimpex in hosting another exciting, interesting, and informative ethics webinar. Good evening to our presenters, special presenters, Dr. Aaron, bioethicist, Dr. Richards, consultant psychiatrist from the UWI, our moderator and chairperson, Dr. Bailey. Also, a special good evening to Mr. Warren and his colleague from Medimpex Jamaica Limited, Mr. Sam Aaron and his technical team we rely on for the smooth and efficient technical operation, which give our webinar such good qualities. Welcome, everyone. And last but not least, Lynn from the Association Secretariat for a tireless effort in bringing all the pieces together for what will undoubtedly be a successful webinar. This webinar is the fourth in the series of ethical webinars put on by the association and made possible by the continued and generous support of our sponsors, Medimpex Jamaica Limited. This evening webinar tackles a very vexing and topical and controversial issues of gender identity and trans rights, and also the more relaxing issue of recovering from the aftermath of the COVID-19 epidemic, which all of us as doctors need. The whole business of gender identity and trans rights is now an international culture war, and I'm sure our panelists will discuss all the nuances of the new gender terms, the issues involved in terms of distinguishing between gender identity and trans right in certain situations. We once again wishes you thanks for attending the webinar and the great support that we get. And I hope at the conclusion of the webinar, we hope you, the audience, will have a great appreciation for the issues involved and the battle lines that are being waged today. Thank you very much, and sorry once more for the late presentation of the greetings.
Thank you very much, Dr. Gordon, for your greetings and your kind comments. Colleagues and friends, we have been together now for almost 2 hours. It is for me particularly a very special moment to have been asked to moderate this webinar on behalf of the Association of General Practitioners of Jamaica and Medimpex. It was a special honor, and I thoroughly enjoyed the moment. I know you also did. And we know that this evening has been an evening which will be long remembered, an evening that was characterized by wit and candor, by controversy, and by music. And we know that the knowledge gleaned will inform our practices and ensure that we continue to practice the art and science of good medicine, recognizing that ethical principles are critical to good health outcome. It's therefore left for me to invite Ms. Paulette Bedward to propose a vote of thanks. And before I do so, it's for me to wish you all a good night and thanks for joining us this evening. And we look forward to seeing you again next year when we'll post another ethics webinar. And this evening will long be remembered for the large number of persons who participated, over 1,000 persons, and I gather over 2,000 on YouTube. Good night to you, and God bless you. And this is Dr. Verson Bailey, meeting office as moderator, and handing over to Ms. Paulette Bedward to propose a vote of thanks. Good night to you.
Good evening, everyone. Good evening. Before I begin with the vote of thanks, I noticed someone had asked in the chat, how do they get in contact with Dr. Richards? Her contact information will be shared momentarily on the screen. You can jot that down. Also, I want to acknowledge the presence of our Managing Director, Mr. Flip Nedick. I saw him online. Sir, would you like to share a few words if you're still on? Dr. Nedick? All right, I'll continue. All right. It gives me immense pleasure to deliver the vote of thanks for this webinar. This event is possible due to the collaborative efforts of a vast network of people. And firstly, I want to start off with our presenters, Dr. Derek Aarons, who presented on the topic, Ethical Dilemmas in Gender Identity. Thank you for an interesting discussion on this very sensitive matter. Dr. Richards, who presented on the topic, A Time for Rest, Recovery, and Repairs. To the team at the AGP, Dr. Donald Gordon, the Association President, Dr. Alveston Bailey, the evening's moderator, and of course, we cannot leave out Ms. Lynn Thompson-Hyatt, the Administrator / Secretariat at the AGP. Also, Mr. Samuel Heron of Oldgate Solution for providing this technical platform on which we are able to gather. A big thank you to all the attendees logged in from home. Thank you for having spent the past few hours with us, the Medimpex family and the AGP team. And this evening, I'd like to do something that I don't normally do. If you would permit me just 2 minutes to say a brief prayer. Heavenly Father, as we come before you, we just want to thank you for all the physicians gathered on this platform. Lord, you know the various homes that we are from. You know the various challenges, the various situations that we are faced with. And God, we ask, Lord God, that you strengthen each and every one of us, Heavenly Father. Help us, mighty God, when we lay down to sleep, when we lay down to rest, God, we ask that you will send angels to empower us, to strengthen us, and give us, mighty God, whatever knowledge and wisdom that we need to make it through, Lord God. We ask, mighty God, for those who are journeying from this location, that you cover our vehicles, send your angels, mighty God, to protect us, Heavenly Father, to go before us and make the crooked path straight. In your precious name we pray. Amen. Amen. All right. Have a wonderful evening, everyone. And remember to rest, recover, and emerge tomorrow as those superwoman and supermen that you are created to be.
Thank you so very much. And thank you again to everyone who participated today. For all our attendees, we thank you for taking the time out. Your CME certificates will come in email shortly. For those who attended on YouTube who are hearing me now, thank you so much for attending. Please fill out the form that you see on the YouTube page, and your CMEs will be coming in shortly as well. Have a wonderful evening, everyone. Thank you so much for joining. I do see that Dr. Nedick had a little bit of microphone issues, but he wishes everyone a good night from the team at Medimpex. So, this is Samuel Heron from Oldgate Solutions saying thank you very much. See you at the next webinar. Stay safe. Good night, everyone.